All right. Hi, everyone, and welcome to the Maternal Health Learning and Innovation Center's webinar, Substance Use in Pregnancy, Understanding Plans of Safe Care for Maternal Health Professionals. And on behalf of the MHLIC, I want to thank everyone for joining us today. So before we begin, we do want to acknowledge that MHLIC is supported by HRSA from the U.S. Department of Health and Human Services, and that today's content and that of the speakers should not be construed as official policy of the U.S. government. Next, we do want to note that everyone is muted upon entry, and that although the regular chat is disabled via webinar mode, we do have the chat Q&A. And so even though there's a lot of information to cover, we will have time, about 10 minutes at the end for Q&A. And so we encourage you to put your questions in that chat Q&A. And we'll also provide an evaluation survey link at the end via QR code. And so we encourage you to complete that at the conclusion of this webinar. If there are any additional questions, please contact MHLIC at www.maternalhealthlearning.org if there are questions that we don't get to today. We also want to acknowledge the partners of MHLIC. MHLIC is comprised of partners dedicated to collaborative leadership in maternal health. Next slide. So for today's webinar, participants, we hope that you all will be able to describe appropriate universal screening, referral, and treatment for substance use disorder in pregnancy, as well as understand what a plan of safe care includes, where to locate resources, and how to identify equitable considerations. We also hope that you'll be able to recognize how to collaborate with partner organizations and community resource providers to optimize care and services for families. And I will now introduce today's speakers, Dr. Mishka Terplan and Jill Gresham. Dr. Terplan is board certified in both obstetrics and gynecology and in addiction medicine. His primary clinical research, public health, and advocacy interests lie along the intersections of reproductive and behavioral health. He is medical director and senior research scientist at Friends Research Institute and adjunct faculty at the University of California, San Francisco, where he is a substance use warm line clinician for the National Clinician Consultation Center. Dr. Terplan has active grant funding and has published extensively on health inequities, discrimination, and access to treatment. He has spoken at local high schools and before the United States Congress and has participated in federal and international expert panels, primarily on issues related to gender, reproduction, and addiction. And second, Jill Gresham serves as Senior Manager of the In-Depth Technical Assistance Program with the National Center on Substance Abuse and Child Welfare at Children and Family Futures. In this role, she serves as an advisor and technical consultant to states, counties, tribes, and regions across the country in issues related to substance use, child welfare, and the courts, providing and coordinating various levels of technical assistance. Jill primarily provides support to states working to address infants with prenatal exposure from pregnancy through infancy. Now we'll now turn things over to Dr. Terplan.
Thank you very much. And just to check, am I sharing the slides or can I even do that? Oh, I can. This is awesome. Okay. Thank you so much. And here we go. You seeing the right thing? Thank you. Delighted to be here and going to sort of lay the groundwork by talking about screening, assessment, principles of treatment, and touch on sort of equity at that intersection of birthing, hospitalization, and child welfare report. I wanted to begin with one of the first articles that describes the benefits of both prenatal care and drug treatment for pregnant people who use drugs. This is an article from Loretta Finnegan from 1978. And in it, she sort of stratified the results based upon these 5 categories of people, whether or not they had a use disorder, whether it was treated, whether they received methadone, and whether or not they engaged in prenatal care. And you can see that the sort of the weight or the population health burden in particular for low birth weight is really amongst those people who had untreated use disorder and did not access any care. But people with treated opioid use disorder who accessed prenatal care had rates of obstetrical complications and low birth weight that are actually much more similar to a population of people without use disorder than to people with untreated disease. And this reflects sort of the core principle of prenatal care, the old adage that healthy mother equals healthy baby, that we optimize maternal health through chronic disease management. And these are data from the state of Massachusetts that demonstrate the same thing that Loretta Finnegan demonstrated nearly 50 years ago. When we look at the population of people with untreated use disorder, that's where the burden of these outcomes are. And people with treated disease, again, look much more like people without any addiction. And so we know that treatment works and improves birth outcomes. But the goal of addiction treatment is not more treatment. The goal is recovery. And recovery is defined by SAMHSA here across a multiplicity of domains. It's a holistic term, it's individualized. There's many paths to recovery as there are people in recovery, and it's a lot more than abstinence. It's a life of integrity, connection to others, purpose, serenity, and it's fully compatible with medication. There is a bit of a disconnect, I think, from this chronic disease management perspective. As obstetrician gynecologists, we actually only provide episodic care, and episodic care is misaligned with chronic disease management. This is a slide from the Guttmacher Institute looking at the reproductive health life course. And roughly the typical woman spends 5 years pregnant, postpartum, or trying to get pregnant, and 30 years trying to avoid pregnancy. So we tend to put all of our programming into the pregnancy box, oftentimes at the neglect of other points in the reproductive health life course. In particular, when we're from pregnancy, neglect of the postpartum period. Pregnancy is a time of increased access to care, postpartum of increased vulnerabilities to return to use, OUD recurrence, overdose, and overdose death. We withdraw care in the 4th trimester, which is precisely actually when people need support the most. And these are data from the state of Massachusetts illustrating that, looking not just at overdose deaths, but all overdose events. And you can see decreasing through pregnancy, only to increase in the postpartum period. And for many states, overdose is the leading cause of maternal deaths. So I want to turn and talk about assessment. How do we identify people who might benefit from treatment? And there's 2 mechanisms that we think of. One is screening and one is testing. And it's important to sort of define some terms. Testing means looking at a biological sample for the presence or absence of parent compounds or drug metabolites. Screening is using a verbal tool or instrument to engage with, to talk with a person about their behaviors. There are 2 types of drug tests, presumptive and definitive. Presumptive tests are the most commonly used ones. They are like the rapid COVID test. They're based on an immunoassay, hence you can get cross-reactivity with the assays, and they're subject to high rates of false positives, as well as true positives that we misinterpret. Definitive tests are more costly. Not every hospital has it. They're send out, but you get not just a binary present or absent of the compound, but you actually get a measurement of the exact substance itself. And the American Society of Addiction Medicine is sort of clear in the clinical guidance to the utilization of drug testing, that if the result of the test is going to inform decisions with major clinical or non-clinical implications for the patient, you should not rest that upon a presumptive piece of information, but you need to rest that upon a definitive piece of information. But overall, like drug tests are overused and misinterpreted in clinical care. There is nothing in the federal statute that says one must drug test, nor is there anything in the federal statute that says a positive drug test must be reported to child welfare. There are differences across the states. And professional society recommendations are clear. If you're concerned about whether somebody has a use disorder, a drug test is an inappropriate tool to use to assess addiction. A positive test is not a sign of health or of ill health. It's not evidence of harm, and it's not criteria for newborn discharge. And professional societies are also clear that consent is required for drug testing. And this is sort of the most recent ASAM public policy statement that touches on this topical area, that equating a positive test with child abuse or neglect is scientifically inaccurate and can lead to an unnecessarily punitive approach, which harms clinician-patient trust and persons' engagement with healthcare services. In contrast, what's recommended is screening, ideally using a validated instrument. And ACOG, SAMHSA, CDC go further and state that participation in screening should be voluntary. There are multiple different screening instruments that have been validated in pregnancy, some of which have been compared to each other as illustrated by these two articles. There is none that is clearly superior, which means whichever screening instrument is already within your EHR is likely to be good enough. But I like to foreground screening in clinical practice, thinking about the voluntarism of participation in healthcare generally and in screening in particular, by asking people permission first. Is it okay if I ask you some questions about smoking, alcohol, and other drugs? And if the person says no, I don't ask. Asking people's permission and respecting what they tell you goes a long way in establishing a therapeutic alliance. Prenatal care happens over multiplicity of visits, so that time is sometimes needed to establish that alliance. One of the problems with the paradigm that ACOG calls test and report reflects on our provider culpability. There's been an enormous increase in the number of infants reported to child welfare in the past 2 decades. That increase has been driven almost exclusively from health professionals. And it's driven to a large extent by, I think, overuse and misinterpretation of drug testing. And it is compounding existing racial inequities. These are unpublished data here on the right, looking at the infant race that were screened in by child welfare over the past decade. And you can see an enormous rise of both American Indian infants and Black infants in this time frame. So one of the reasons that people report to child welfare is this recognition that the people we're serving have needs and that we want those needs to be addressed. But instead of addressing them within the health system, we report those people to the child welfare system. I will also say that I think many of us who work in this space do not understand exactly how child welfare functions and what happens. And people are not necessarily more safe in foster placement than they are with their families. 20% of children experience abuse or neglect in out-of-home placement. When you compare kids in foster care to kids not in foster care, they have a higher burden of mental health and somatic conditions. We see toxic stress within foster placements, which is really defined as the physiological result of dangerous, recurrent, or prolonged experience of trauma caused by the initiation of a stress response without the protective existence of a compassionate adult. And both parents who lose children into the system, as well as children themselves, experience non-death loss and grief. There has been a good literature looking at the population health consequences of mandatory reporting. And there's no evidence that mandatory reporting actually improves population health. And punitive policies in general, which include not just mandatory reporting, but coerced treatment and the statutory designation of drug use in pregnancy as child abuse, are associated at the population state level with no improvements in birth outcomes. In fact, with an increase in the odds of neonatal abstinence syndrome, an increase in the odds of low birth weight, increase in the odds of preterm delivery, and a decrease in the odds of any prenatal care. From the perspective of the fetus does not know if the substance to which it was exposed was prescribed, was used as directed, was misused, is a legal substance or an illegal substance, is a natural substance or a synthetic substance. But we apply the classification of substances, which is a social and legal classification, onto assumptions about biology and public health. And that's a false assumption. Things that are illegal are not more harmful than things that are legal or prescribed. In fact, from the perspective of the fetus and of the pregnant person, it's the illegality of the substance that confers the harm, not the chemical makeup itself. From the perspective of teratogens, substances that can cause birth defects, out of the hundreds of thousands of known chemicals in the universe, only a small amount actually are teratogenic. And those that have been described are either medications we prescribe or things that are legal. None of the illegal substances are teratogenic. The one substance that is teratogenic is alcohol. It's the leading cause of preventable intellectual disability in the United States. It's the one substance that's least likely to be positive in a drug test. And it's the one substance I think that we grossly underdiagnose and underaddress. So the states that have this sort of statutory association saying using drugs while pregnant is equals child abuse, that's actually a non-scientific statement. It's an example of a logical tautology, something that's defined in reference to itself only. In other words, it's something that's formally undecidable. It's not falsifiable and therefore not scientific. So it's actually a statement of belief and not of science. Looking at the evidence, there's one systematic review that looks at whether or not people who use drugs in pregnancy are going to subsequently abuse or neglect their infants. What this review found was that substance-exposed infants are more likely to be involved with child welfare. We know that reflects that statutory, tautology that I just mentioned. But these authors did not find any strong evidence of substantiated maltreatment or neglect. And in fact, they said that the overall quality of the published literature was poor. And it's for these reasons that when HHS convened a work group and had a whole process to come up with a new definition of neonatal abstinence syndrome, we insisted that we have sort of principles in place around the diagnosis. Principles that are illustrated here in table 3 of the published document. That addiction is a disease requiring compassionate, ethical, equitable, and evidence-based care, that the dyad is the appropriate subject of care, that a diagnosis of newborn withdrawal does not imply harm, should not be used to assess child social welfare risk or status, should not be used to prosecute or punish the mother, or as evidence to remove a neonate from parental custody. So in this space, I think it's unique in that pregnancy and addiction is a space of mutual mistrust. Providers, our mistrust of patients is often misplaced, rooted in discrimination and prejudice. But patient mistrust of us is warranted. It's legitimate based on their own experiences of discrimination in healthcare settings, as well as in the historical memory. Now, what happens if I trust a patient I should not have trusted? The consequences to me are minor. What happens if a patient trusts me, but they should not have trusted me? The consequences of that misplaced trust can be severe. And this reflects the power differential of care, which means that the risk and vulnerability is different between the provider and the patient. And most importantly, the responsibility for overcoming mistrust rests with us and not with the patients. And one way that we can build trust is through clinical discussion. We can resist stigma and discrimination by speaking, by asking questions that center on the people that we serve. What is the most important thing to you about treatment or recovery? What do you know about methadone? Do you have any fears or concerns? What do you need to feel safe? What are you looking for in a provider? And how do you feel your care is going? Because when we put it all together, the work that we do should be both evidence-based and person-centered. By evidence-based, I mean grounded in science. The harms, generally speaking, the harms of illegal substances are exaggerated, but we minimize those of legal ones. And more importantly, we overstate the importance of an intrauterine exposure and neglect the role of the caregiving environment. And by person-centered care, this is care that's ethical, grounded in human rights, which recognizes reproductive health as a human right, which is the right to determine whether and when to become pregnant, as well as the right to raise children in safe and sustainable environments. Human rights means supporting autonomy and maternal subjectivity in decision-making around pregnancy, and remain attuned to the unique demands we place on pregnant and parenting people, on their bodies, and on their minds. And with that, I'm going to stop. I want to just share with you the information for the substance use forum line. I look forward to the questions and answers and how we can talk about how the plan of safe care is a wonderful tool to support recovery. Thank you.
Thank you so much, Dr. Terplan. That was awesome. We did receive a few questions in the chat. I'll save the questions about the content until the end, but regarding sharing of the slides, we do have permission, I know, from Jill to share slides, and Mishka, okay, great. So we will make the slides available as well as we are recording this webinar. So with that, I will now turn things over to Jill.
Great, thank you. All right, hello everybody. So I'm going to get into the weeds a bit in terms of plans of safe care. So quick acknowledgement on my end, just to note that I'm here with the National Center supported by the Children's Bureau and the Administration of Children and Families, as well as SAMHSA, which is the Substance Abuse and Mental Health Services Administration. We really focus on that intersection between child welfare and parental substance use and try to build bridges and break down silos and bring systems together to support families. One just piece of data to talk about before I jump in, and Dr. Terplan talked about us seeing increasing numbers of reports coming into child welfare, sort of what it looks like on the other side. This is the number of kids who are going into out-of-home care in the United States for any reason, broken down by age. And so you can see the number of kids under the age of 5, right, accounting for almost half of those kids going into out-of-home care. And then when we look at those kids under the age of 1, that number really just skyrockets. So this, again, is any reason, but when we see kids that age going into out-of-home care, there really is a red flag around substance use being a driving factor. And in fact, I was with a state recently where they were able to take that data and dive in a little bit deeper. And what they found was 75% of these kids under the age of 1 going into out-of-home care were there because there was a parental substance use issue. So this is something that we're looking at, and we think plans of safe care can help us in terms of keeping those kids home with their parents. So I'm going to talk about plans of safe care. And when we talk about plans of safe care, if you're not familiar, it came to us through the Child Abuse Prevention and Treatment Act, or CAPTA. CAPTA is a really broad piece of legislation that addresses many different components of child welfare practice. It comes to us in 1974. When we're talking about it, we're talking about a passage related to infants born exposed to substances, and that first appears in 2003. There's an amendment in 2010, and then there's another amendment in 2016. So basically this piece of legislation mandates that infants born affected by substance abuse, withdrawal, or fetal alcohol spectrum disorder need to have a plan of safe care. So this law has been with us since 2003, but in 2016, they struck the word illegal. So it used to say infants affected by illegal substance abuse needed to have that plan of safe care. And now it's broadened that population of infants who need to have that plan of safe care. So it could be a mom, maybe there was some marijuana exposure and there wasn't any concerns for risk or safety, or maybe that mom was on methadone and is stable in her recovery. So again, no concerns about risk and safety. And so those families still would benefit from a plan of safe care. So it's sort of widen the population who needs those plans of safe care. The other big thing to be aware of with this change in 2016 is that they brought in the plan of safe care to focus on not just the needs of the infant, but also the needs of the primary caregiver. So the intention was that it really is a family plan. So as healthcare providers, some things to think about or things to be in the know about with plans of safe care are first to understand who in your state needs a plan of safe care. So the legislation again says infants affected by substance abuse, withdrawal, or FASD need a plan of safe care. That language can be a little vague, and some states have come together and defined that a little bit more clearly. So it could look different in your state versus another state, right? So that's one piece, and I wish I could say to you, this is what it looks across the whole country, but unfortunately, it doesn't. There's differences from state to state. So that's sort of a first piece, is really understanding who in your state needs that plan of safe care. Second is that some states have developed different pathways to get to the plan of safe care. So I mentioned earlier that there could be some families who need a plan of safe care, but there's not risk or concern about child welfare or the need for child welfare involvement. There's no risk or safety concerns coming up. So some states have said, well, if there's no risk or safety concerns, let's create a secondary pathway that goes to a community provider. And then there's the same pathway that goes to child welfare if there is some child abuse or risk concern. So essentially two different pathways. Not all states have done this, but it's good for you to know as a healthcare provider if that exists in your state, because you might be able to bypass the child welfare system for certain families where there are no risk concerns. The third thing to know is if your family has that kind of notification pathway set up, is where are those families going, right? So in some states like Rhode Island, public health takes a lot of those families. In other states like Delaware, there's a contracted substance use disorder treatment provider who takes those families. In Washington State, they're working with Help Me Grow, which is like a phone-based referral system. So again, looks different in different states, but good to know where these referrals are going and how to get them over there and partner. And then finally is the plan of safe care template itself. So the legislation says the plan of safe care needs to address the health, development, and substance use disorder needs of the infant and the caregiver, but they don't give us a template. So some states have a single template that's used all over. Some states, it gets all the way down to the agency level. Sometimes communities or hospitals or counties have their own plan of safe care. But again, something good to do a little research on. And usually you can find this stuff with your child welfare agency and sometimes Department of Health. Lots of states are setting up good websites that contain a lot of this information. If you're not familiar with a plan of safe care, it's different than a child welfare safety plan because it goes beyond safety, it goes beyond SUD treatment needs, and it goes beyond hospital like health focus needs. Really, it's a family plan that's supposed to help bridge collaboration so that providers are all talking to one another in support of that family. These range from a single page to something like 20 pages. It was like the biggest one I've seen in Delaware. And so there's actually a version in Houston that is actually a binder, so I guess bigger than 20 pages, that the mom carries around with her from appointment to appointment as she's getting ready to give birth. So they really are meant to be like an information sharing tool for that parent to use. So when we talk about who needs a plan of safe care, again, this may look different in your state than the state next door, but it tends to look one of these three ways. So the first way is that the state doesn't really do any defining, that they just take that federal language, which is affected by substance abuse, and they let healthcare providers make a determination. So if the healthcare provider who's involved in that delivery says, yes, this infant is affected, then that infant needs to have a plan of safe care, and oftentimes that healthcare provider will start that process. In other states, like I said, they've done some defining around it, and usually that defining comes down to some kind of tox test result. So the first one is, if at the birth event there's a recognition that there was substance abuse, so there was a positive test for the mom or the infant, or the mom verbally talked about substance use, then that's the trigger for the plan of safe care being completed. In other states, that tox testing might go into pregnancy. So they might say if there was substance use in maybe the last trimester, that family would be then eligible for the plan of safe care. So again, may look different in different states. So the justification for creating those two pathways really is that oftentimes families that had some issues, they might have been referred to child welfare and screened out because there were no risk concerns, but they still needed something. And oftentimes when they get screened out, they don't get any of those services. So the idea with the plan of safe care, and in the legislation, it specifically says that this notification for the plan of safe care is not to be construed as a report of child abuse or neglect. So it's different from a report. It really is about trying to get these family services so that they don't end up popping up in the child welfare system. We want to get them what they need, right? So they can be healthy and safe together. So these pathways were created out of a recognition that maybe these families do need some more services, but they don't need that sort of heavy hammer of the child welfare system. And how can we provide them with the services they need in partnership with our community providers, so that then that family knows where to go, right, if they need ongoing supports and services. So I want to talk a little bit about how these notification pathways look and operate. And again, there may be some differences in your state, but this is what the pathway looks like if there is no separate notification pathway. There's just one pathway. So in some states, it just is sort of business as usual, where a healthcare provider recognized that there was some exposure. They call child welfare screens in or screens out, but they handle the plan of safe care. In many states, if child welfare screens out or doesn't see any kind of risk issues, they have sort of a sort of lower intensity level that they'll work with these families within that track. So sometimes they're called assessment tracks, sometimes they're called voluntary tracks. But they'll support those families in that track, but it's still under the child welfare umbrella, and child welfare will create the plan of safe care. When a state does have a notification pathway, it tends to look one of two ways. So this might be happening in your state, where first the healthcare provider does the same thing. They see exposure, they're not sure if there's any concerns, they call child welfare. Child welfare does the screening that they've always done. They screen in if there's a risk issue and they do the plan of safe care. But if there is no risk issue, they screen out and they send that family to a community provider. And again, this looks different depending on where you are. So it might be you're in Rhode Island and that maybe goes to a public health. Or I think I was talking with a team, I think it was in Louisiana, but I might be misremembering, but where there was an MOU in place to allow child welfare to send those families over to public health, and then public health is a plan of safe care. But child welfare acts as the sort of the decision maker. The other version of the notification pathway moves the decision upstream to the healthcare provider. So the healthcare provider makes a determination like, yeah, there's some risk stuff here I'm not sure about, I want to call child welfare, or I'm not really seeing any concerns here. There's some exposure that happened, but I'm not seeing any risk or safety concerns. If they call child welfare, it proceeds as sort of usual. Child welfare does the screening and usually does the plan of safe care. But if they're not seeing that risk, then they essentially sort of bypass child welfare and they send the referral to a community provider. So again, and this is one of those pieces that looks different from community, but that healthcare provider is then directly connected to the community provider. And in many states, the healthcare provider will develop sort of an initial plan of safe care and then send it to the community provider that will help the family engage in those services to get the supports they need outside of that child welfare system. So determining when a report is required for systems that operate like that can be a little bit dicey for healthcare providers. But there's a couple of tools that we're seeing. So in some states, there is actually legislated, law about when to report and what to report and who gets reported. So that's sort of your first guidepost. Or are you in a state that has these reporting requirements? If not, there's a lot of states that are starting to handle these notifications about like who gets a plan of safe care and when to notify and when to report through guidance. And oftentimes that guidance is coming out through the child welfare system or through Department of Health. And again, you can oftentimes find that on websites and things. The other thing that states are starting to develop, if they do have these notification pathways, is they're starting to develop some tools to help healthcare providers with determining, do I need to call child welfare or not, and like how to do some of those assessments. So Connecticut and Washington come to mind. They created these nice decision trees about, do I need to call or not call, to help determine risk. And Los Angeles for many years has had this really nice assessment tool for healthcare providers that has a rating scale across numerous different fields to help providers make a determination about, yeah, there's some risk here that I'm not comfortable with, so I think I'm going to call, versus no, I'm really not seeing risk in this assessment, so I'm not going to call. So we have some examples of those tools. I'm always happy to share those with you, but you probably can also find some of this stuff within your state child welfare and DOH agencies. So I want to show you quickly a couple of maps of the states that currently do have some kind of legislation. So this is not going to get into policy, but some of the legislation that's out there. So Dr. Terplan talked earlier about some states that do essentially codify exposure as child abuse or neglect. And so what you see on the screen now are those states where those laws are currently in place, which would mean that that exposure would lead to some kind of a child welfare interaction or involvement. The next one is where some kind of prenatal exposure requires a report to child welfare. So in these states, there might be some language that says you don't have to call us if it was prescribed, but if it was illicit, then there needs to be a report. So, but exposure in some way needs to have a report. So you can see those in all these little yellow pyramids or triangles there. So these are the last two maps together, just so you can get a sense of these are the states where you're probably going to have to report something related to exposure and neglect. And I will be sending these slides up so you can have that information as well with you. This last one shows you states where the notification pathways, so those secondary pathways, have been codified into law. So I will tell you, there are other states that are doing notification pathways. They're just not legislated, right? They're done in policy and in partnership with hospital associations and child welfare usually. But the states that you see on the screen now in blue are those that actually have legislation that says, under these circumstances, we want you to notify us. So finally, here's a final map that just pulls them all together so you can get a sense of all the different states and all of their different requirements. So last piece for me today, I just wanted to talk about building a supportive response with plans of safe care. So how do we really support families in this work? I want to talk a little bit just about the prenatal and the birth space and then moving beyond that. So Dr. Terplan talked a lot about universal screening and the referral process. So I won't go too much into that, but we need to identify these women, right, to be able to provide them supports. I think the other piece too is thinking about engagement, and the pros of engagement in this space are people with lived experience. So if we can engage people with lived experience in more medical settings, we often see them in emergency rooms around overdoses and things like that. But there's some more opportunity to bring them into this prenatal space to help them if we have a mom who's struggling to get her into the services that she needs. The more when we can identify pregnant people, we can identify during pregnancy and get those supports, the fewer women we're going to see end up in that child welfare system. So just a big push to that prenatal space. At the birth event, just thinking about the family-centered response. So that plan of safe care, again, is about the family. So how do we support that mom and child to be together, that mom and dad and child to be together in that space using methods like Eat, Sleep, Console, or if mom and dad do need treatment, are there residential options where they can go together so that we don't have to separate them? And then finally, that beyond period of time, but what's happening after discharge? How can we engage these families with home visiting services so all those services don't fall away when she goes home with that child into some type of stressful environment where she needs those supports that sort of fourth trimester. And the other thing is just to think about early intervention. So making sure we make those referrals to early intervention so that those families can get the services that they need. So I've talked a little bit about a prenatal plan of safe care, and those prenatal plans of safe care are not required by legislation. However, they just really do make a lot of sense. So they are opportunities to, we see this pregnant person, we know that that baby is coming, we know that there's a chance that there's going to be some exposure going on. So how can we really start wrapping those services around her in the prenatal period so that when she gets to birth, it's not a surprise, oh my gosh, we have an exposed infant, child welfare is coming, and there's going to be some kind of a removal. So how do we have those conversations about substance use during pregnancy so that we can get her and the family the supports that they need to avoid that crisis moment at delivery? So again, not mandated by the CAPTA legislation, but we are seeing more and more states moving towards building out this prenatal plan of safe care process. One of the best examples, I mentioned this earlier, was this binder model out of Houston, Texas, where they have something like 25 providers in town that are all part of this. And so mom brings a binder around from appointment to appointment. It helps the providers know what she's doing, what support she needs. It helps mom have everything in one place, and she oftentimes calls it a recovery resume. So she brings that with her even to the birth event. And it's also an advocacy tool if needed with child welfare at birth to say, this is what I've done and how I've prepared for the birth of that infant. So how can you get involved if all of this is sort of piquing your interest and you're wanting to change some practice locally? I think the one piece is that Dr. Terplan talked about is how can you integrate universal verbal screening using an evidence-based tool? That might be one easy win, one quick change to integrate. Also, if this is new to you and you haven't heard about plans of safe care, do some research about what's happening in your community. I think every state at this point is on board with plans of safe care in some way, shape, or form. So reaching out to your local child welfare offices to understand like who needs a plan of safe care in our community, and is there a template, and how are these things rolling out? Do we have a pathway? What can we do as healthcare providers at the hospital level to start to build this out? If you don't have a plan of safe care template that's in use, it's something that you can build on your own if your state's not using one. Again, I have lots of examples, so you can absolutely reach out to me and I'd be happy to give you some pieces to work off of to make them your own. At the policy level, there's probably, if you're researching what's happening in your state or your community, it's likely there's a state team that's working on this, that's trying to finalize those definitions or flesh out a pathway or update legislation or things like that. So they're always looking for more healthcare providers to be a part of those teams. So I can almost guarantee that you'd be a welcome addition if you wanted to reach out and do some of that policy level work. And I'm just always going to do another plug for, advocating for the greater role of people with lived experience, because I really, like I said, they are the ones that often make the change happen and can really create that sort of a stigma-free environment and support people who are moving towards recovery. So I was also just talk a little bit about resources. If you reach out to your state and you're like, we just can't find anything, there's nothing out there yet, they don't have a website, you can always come to us and we will do what we can to help you out. We have relationships with many states, and we've been doing this plan of safe care work with states since 2015. We've hosted policy academies. We've worked with at least half of the states in the country. At this point, probably more. So we probably know what's happening in your state if you can't quite figure it out. So again, we're the National Center of Substance Use and Child Welfare. If you haven't checked out our website, it's absolutely chock full of all kinds of resources. We have a tab that's specifically about infants born prenatally exposed, so you can go and poke around there. You will find resources like we have these learning modules that help you. If you have nothing going on in your state, it will take you from the preparation stage all the way through defining and implementing the plan of safe care itself. If you're beyond that and just curious about examples, we have another set of modules that just talks about this is what it looks like in several states. So this was, I think, from 2020 or 2021, so not too old, but you can get a sense of how states have defined affected by and handled notifications and what the data looks like and what their challenges were related to implementation. We have a new brief that's looking specifically at that out of an equity lens at this population, so parents with substance use disorders and the child welfare population. When I was talking about healthcare providers figuring out risk and whether or not to call, that can be a really tricky issue. It's something we could have probably talked this whole time about. But we do have a risk and safety video series that's been rolling out. So if that's something that you need, that could be a good tool for you. And then lastly, we have these online tutorials for cross-distance learning. So if I'm talking about substance use disorders and residential care, and you're like, how does somebody get assessed that way? This is the tutorial for you. It will walk you through sort of like SUD 101. And then we have another one that's specifically about the child welfare process. So if that's sort of a black box for you, you don't understand how the investigation process works or the court process, all of that stuff is lined out for you in these tutorials. So the other thing is you can always shoot an email directly to me or to the National Center on our National Center mailbox. You can find us. I would just say don't reinvent the wheel. Like I said, we've been doing this work for a long time with states. I have examples of treatment plans and plans of safe care and definitions, and we have been working with healthcare providers across the country in a number of perinatal quality collaboratives. So we can connect you with somebody that's been doing this work or give you an example of a concrete tool. So thanks. I think we have some time for questions.
Awesome. Thank you so much. We have had many great questions come into the Q&A, and I don't think we'll be able to get to all of them. I do want to say, for those who asked about more specific state and local examples, as well as maybe clinical and hospital examples, we will be having a second webinar in this series where you'll hear from state and local implementers. And so you'll get some of those pieces about more of that specific implementation in settings with different legislation and different approaches. So hopefully you'll be able to attend that May 16th from 1 to 2 EST. That's registrations available on the MHLIC website. So I will go ahead and field the questions. How can we better the relationship between child welfare and birthing persons who use substances? I find that in my work, a lot of mothers might not admit to drug use because they are afraid their baby will be taken away. And I do want to open that up to Mishka and Jill. Mishka, I'm not sure if you're able to turn on your camera, but if not, we'll also just hear from you.
Yeah, it looks like it's disabled for some reason, but that's, yeah, I have a face for radio. I think that's a super important question. And it's not just our relationship with child welfare, but also like primarily our relationship with the people that we serve. And so this question, like recognizes the legitimate mistrust, that patients have around, sharing information related to drugs and stuff like that. I think with the people that we serve, one thing is to be very clear and honest about what happens with information and what our responsibilities as health professionals are. And depending on who we are, that responsibility can extend beyond, the actual clinic itself. So that means that we can follow people into family court, we can write letters, and we can do that. In terms of your local child welfare, there's nothing better, than actually meeting them. If you have a drug treatment clinic, and having them come and see. Many people, not just people who work in child welfare, but people in general, do not understand and do not appreciate, what addiction is, much less what recovery is. And just like Jill was talking about the importance of integrating, peers and people with lived experience into the work that you do, sort of like sharing treatment and recovery experiences and stories with child welfare, I think can go a long way in removing some of the, stigma and discrimination that they too sometimes have.
Yeah, I'd agree. Just transparency with pregnant people about what the child welfare process is, so that they know what to expect and what the potential is for, that call being made at the birth event. So my history was as a substance use disorder treatment professional. So we had lots of conversation if I was working with a pregnant person, kind of leading up to that and what the potential was of child welfare being involved. I've also seen providers who have invited, as Dr. Terplan was saying, invited child welfare into the space, invited them into treatment groups to talk about the child welfare process, again, to sort of demystify it, to drop the anxiety a little bit about what might happen, and just for those moms to get some clarity.
All right. Another question. In states where there is a two-tiered referral system, what evaluations have been done, if you know of any, on whether this exacerbates class-based and/or race-based inequities in child welfare system involvement?
Yeah, so probably we're just starting to see data come out. And so Connecticut is probably the state that has been collecting the most data in terms of outcome. What Connecticut has done in a lot of states that are doing these notification pathways, a lot of the information that child welfare gets is de-identified. So they don't know who the families are and if they sort of re-pop up back into the child welfare system, but they do have an understanding of race and ethnicity and who is being reported to child welfare versus that de-identified notification. So the good news is that they did see something about half, 50% of those infants who were born exposed were diverted away from the child welfare system, but they were still seeing a disproportionate number of Black women who were still being either notified or reported, and they were seeing especially around marijuana use. So disproportionate Black mamas marijuana use were still making it either to child welfare or through that notification portal to a plan of safe care. So that they're the one state where I've seen a fair amount of data. Other states are still getting their head around collecting that data. But Dr. Terplan, wondering if you've seen any other data on that.
No, I mean, I think the Connecticut's like so-called masked assessment, which was a step in the right direction and not completely masked, in my understanding, and not published. I don't think the outcomes are published yet, but I think this question does relate to, like, I mean, thank you for bringing class into this, because it does. I think there may have been a reduction. I don't want to overstate this, but a persistence, but a reduction in racial inequities with masked assessment. But I don't think there's been any change in class. So inequities in class. And yeah, Connecticut would be the most sophisticated state that I know of for those kinds of data.
Thank you. We have time for maybe one or two more. So I'm sorry, we have so many good questions. We may try to compile some of these and send out additional information for those who registered. But what are the consequences if a parent does not consent to or fulfill the requirements set in their plan of safe care?
So this is one of those things that does sort of vary state to state, but in those states where there's a notification pathway and there's been no risk identified and it's sent to a community provider, those are completely voluntary. So if the parent chooses not to participate, they choose not to participate. So therefore, much of the plan of safe care work is really pinned to good engagement. So in states where child welfare is overseeing all of them, that may look different. So like a refusal to participate might bump somebody out of a voluntary track and into a more sort of CPS oriented track. So it could look different. But I think in those states where they do have those notification pathways, for the most part, many of those are voluntary.
And I just, to add to that, like, to me, the plans of safe care are a tool, and they can be done well or they can be done poorly. And when they're done well, they really rest on the person that we're serving, right? So it's, the plan is comprehensive and it's individualized, and it comes from what they, what their goals are. And it's, and they know the providers that they're with, ideally. And so then we advocate, there won't necessarily be deviations, or non-adherence, if it's truly, comes about collaboratively and in particular, like centers on them.
Okay, and this is the last question. I think we'll just take this up to the close of the webinar. We can send the evaluation link out at the conclusion to those who registered. So please be sure to send that to us. We see there's interest. So thank you again. But the last question, I'll try to combine a few of these. Folks are asking about if, Dr. Terplan, can you comment again about universal testing on L&D, as well as I'll combine that with asking about a sense of which universal screening tools are used most often in the clinical setting, and is there evidence that self-report or verbal report with a provider is more accurate?
Yeah, so I was taught as a medical student to only order a test, any test, the result of which will change clinical management, and to only order a test that I can interpret correctly the results. There's a small literature on physicians' ability to interpret urine drug tests that's not reassuring. We do not actually interpret, especially like, presumptive tests very, very well. And second, most of the time, we are not ordering drug tests for clinical indications. We're ordering them under the sort of misinformation that they're required by, state or even federal law, or sometimes under the misinformation, that they're required, for child welfare reporting or for within hospital policy. Now, there are some states that do require drug tests. There are, some hospitals that have policies, explicit for this. But most of the time, we think that they're there. And when we go down the rabbit hole, we don't find the explicit policy. So testing, and then the idea that if you universalize testing, you're not going to contribute to inequities. That might be true for testing itself, but it's not true for the consequence of the test, for how the report is made and what happens, to that infant and to the parent within the system. So what's recommended is, is screening using a validated instrument, which are, the NIDA quick screen, the 4 Ps, the 4 Ps plus, those might be those that are, most commonly used. And for which, which are amongst those that are validated and have been compared to other ones. There was a question, and all, just to be clear, like, ACOG and ASAM, like the statement is like explicit written consent prior to drug testing. And that consent concludes why you're doing the test, what you're going to do with the information, and what, how that piece of information might be shared. And as with all consents, it should rest on the patient right of refusal.
All right. Well, thank you so much. I think that takes us up to 1 o'clock. Again, reminder, we do have a second webinar in this series that is available for registration on the MHLIC website at www.maternalhealthlearning.org.
That's under 16th. Events. You can find it under events.
Thank you. Yes, find it under events. Please register. That will have more of the specific state and local implementation information. We will send out an evaluation link. And beyond that, we just want to again thank Jill and Mishka. Thank you so much. We really appreciated this, and thank you for all the great questions. Thank you everyone for attending today, and have a great rest of your day. Thank you.
Thank you.